All right, thanks for the nice introduction, for the invitation of presenting the work that we have been doing for the last couple of years in Ghent in the cardiovascular device space. So I changed the title a little bit to make it very complex. So we'll talk about TAVI. Now, what is TAVI? For those who are active in the orthopedic field, they might not be familiar with that. TAVI is a minimally invasive approach to treat aortic stenosis, aortic valve stenosis. So if you look here to the picture on the right, you see here the three leaflets of the aortic valve, the valve between the ventricle and the aorta. And if this valve gets calcified, of course the opening and closing of the valve is dysfunctional. And this can now be treated in a minimally invasive way with a big stent putting in place. So what they do is they insert a catheter here, the blue line, from your groin. At the end of the catheter there's a device. This device is deployed, is pushing away the old native valve to the side. And in that device, in that stent frame, there is a new valve that takes over the valve function. Now this is very promising technology, and if you look to how these procedures are currently planned, this is based on medical imaging. So what they're doing is based on the medical images of the patients. For TAVI, it is mainly CT based. From the CT scans, they take measurements, and based on these measurements, they decide on which device size to put. Like in shoes or in implants, you have different sizes, so there needs to be a selection. And this is based on the annulus diameter for the aortic valve. Now the problem is that measuring on anatomy is apparently not good enough because there are still some complications which are present. This is a pretty busy slide, but the only thing you should look at are the two arrows on the left. What you can see, there's one arrow pointing up, one going down, and this is a summary of all clinical data of the latest clinical trials in terms of the devices which are on the market. So we have different players in this space. So you have, for example, the devices from Medtronic, Edwards, and Boston Scientific. And what is summarized here, this is one complication. This is permanent pacemaker implantation. The other one here is PVL, this is leakage. Now, if we deploy the valve inside the anatomy and the positioning is not good, then you might have regions where the blood will go back to the heart when the valve should be closed. This phenomenon is called PVL, or paravalvular leakage. And in the early days, with the first generation devices, this was still pretty high. So let's say above 10%, sometimes even above 20%. With the newer generation devices, they have tried to solve that problem, and indeed the PVL rates have been going down. So it went up from, let's say, all above 10 to way below 10 for the newer generation devices. So problem solved. Taking a closer look at other complications, we see that here the arrow is not going down, but it's going up. And this stands for permanent pacemaker implantation. So what has been observed is that after putting a TAVI device, there are problems with the conduction system, and you clearly see that here these pacemaker rates are higher than in the early days. So pacemaker rates seem to be going up. Now, if you look from a very simple point of view, why is this occurring? Well, because you have two counterindicating factors here. If you want to reduce PVL, you should try to do two things. One thing is, of course, you should try to avoid undersizing. If your device is too small, for sure it will not oppose well, and you will have leakage. What you also try to avoid is to avoid too high implantation depth. If you position the device too high, then again you have more risk of leakage. Whereas if you want to try to avoid pacemaker placement, there are different hypotheses there, but there seems to be consensus that you want to try to avoid oversizing, so you don't want to size too aggressively, and also you want to avoid too low implantation. So how to find a good balance between these two factors? What we have been developing is combining in a functional way these medical images with advanced computer modeling, finite element modeling, computational fluid dynamics modeling, to get a good idea of how a device interacts with the anatomy preoperatively. So we start from the routine clinical imaging, so CT scans are there anyway. We make, with mimics, that's why I'm presenting here, a 3D computer model of the anatomy. We have a library of devices, and preoperatively we can look at the interaction between both. This is also illustrated here, so you have seen these types of movies already lots of times, but we also have a movie like this. So CT scans, you transform these CT scans to a 3D model. From the 3D model, you zoom in on the region of interest. There we change it to a finite element model with different mechanical properties for the aortic root, native leaflets, the calcifications. We model with finite element modeling the deployment of the device into the anatomy. Subsequently, we analyze whether there's malpositioning or not, and we quantify that malpositioning by doing a flow simulation to see where is the leakage occurring and how severe is that leakage. This is what has been seen here. Of course, key, and that's probably what everybody's thinking here, how accurate can you do this? So we tried to validate this to as good as we could, and we did quite some work retrospectively. So one of the first studies we did was together with the colleagues in Rotterdam and in Antwerp and in Paris, where we did a study on 33 patients, and for these patients we both had preoperative and postoperative CT scans available. And you can see here on the left, this is a prediction of the computer model. On the right, you see a post-op image. We can, of course, then take different cross-sections and look to the strut distribution. Can we predict how a frame deforms inside a patient? We did this, as said, for a study on 33 patients. And this is, for example, the difference between, or this is the diameter, the maximum diameter measured from the post-op CT compared with the maximum diameter at the inflow region from the computer model. And as you can see, correlation is for sure not too bad. Next thing we looked at is, can we also predict what happens with the anatomy? So we can predict how the frame deforms, but can we predict accurately how the anatomy deforms? So what we did here is we quantified the distance between the calcifications, which are clearly visible on the post-op CT scans, and the coronary ostia. And we compared that distance for both ostia with the prediction from the computer model, and again, correlation was good. What we can observe here is, this is a qualitative comparison of how a device deforms. It's, let's say, for 4 different patients, and these 4 different patients were treated with exactly the same device size and exactly the same device type. You can see that these devices deform quite differently. Yeah? So depending on the anatomy and the disease state of the patient, these devices adapt in a different way to that anatomy. And what you can also observe from a qualitative point of view is that our model is able to predict that. So we can quite accurately predict the interaction between the device and the anatomy. Now, can we predict leak? Yes, we can. So what we did here, this was a study on 60 patients. And what we did is, so we did a mechanical deployment. We made sure that the device was in the same position as was done on the patient. Then we did a flow simulation. And we compared the results of our computer model, which are here on the y-axis, with the results from the clinical information. So all these patients were given a Cellar score, grading them how severe the leakage was. And this goes from 0 to 3. For 0 and 1, this is a pretty low to mild or non-leakage. 2 and 3 is mild to severe, and there is clinical evidence that there is an increased mortality at year 1 if you're in this group. Yeah? So if you have a Cellar score from 2 to 3, you have much higher chance of dying after 1 year than if you would be in this group. And it seems that, if you do some statistics, if you would specify, based on the computer model, preoperatively, that you would have a cutoff value of 16 ml per second, if you're below this value, you're of course in the low risk group. If you're above that value, you're in the high risk group. And we can predict this with the sensitivity and specificity of 0.8. Now, how can we use this technology? For example, we can assess what is the impact of positioning. Physicians have the liberty to position it in different positions in the patient. So here you can really quantify upfront for a particular patient what is now the impact of putting it from high to low. And it is very clear that for this patient, putting it lower reduces the PVL, which is consistent with the clinical data that we presented earlier. What we have done then is, for example, here we did a study that we investigated for, I think, 34 patients, different implantation depths, and also for different devices. So we compared the core valve with the core valve Evolut R. The Evolut R is the newer generation device of Medtronic. And it is very clear that on the one side, in terms of positioning, the lower you go, the lower the leakage is. But also what is observed is that the core valve Evolut R is indeed does better, or as compared to the core valve, in terms of reducing PVL. Now, it's not always the case. Here you see, for example, comparison of a case with a core valve and an Evolut R, where if you put them in exactly the same position, it does not matter that much. So it's really on an individual basis that you have to decide on whether that device will stop the leakage or not. Also, size matters. Of course, everybody knows that, but this is also proof in this slide. So what we have done here, this was a patient treated in Rotterdam about 2 years ago, where based on the current treatment planning, they did the measurements on the anatomy. They measured a diameter of close to 22.8 millimeters. Now, if you look to the sizing chart of the core valve, then the physicians have the choice to put either a 26 or a 29 millimeter core valve, because always you have to oversize the device a little bit to make sure the positioning is well. But physicians had the choice. We can put a 26 or a 29. There is no real clear decision to be made. They chose the 26, they implanted the device, and unfortunately for that patient, a moderate leakage was observed. Retrospectively, we analyzed that patient, so we put the 26 millimeter device in the patient, and we would have predicted that. So here, our computer model, where the leakage occurs, the severity of leakage was predicted with our computer modeling. And if in that patient they would have implanted a 29 millimeter valve, the patient would have go from above the limit of 16 to below the limit of 16. So bringing highly probably from the high risk to the low risk group. And this is information that we could have given them, of course, if the technology would have been available at that moment in time. Now we talked about two complications and to try to find a balance between these two. So I think in terms of leakage, we have now data on close to 60 patients that we can predict leakage quite accurately. We then did a study on, okay, but also can we predict what happens in terms of conduction disturbances? Thank you for the 5-minute warning. I will try to be on time. What people know is that, or let's say there is hypothesis that the membranous septum is an anatomic landmark for the location of the His bundle and for the origin of the left bundle branch block. So this membranous septum is pretty important. And this can also be observed from the CT scans. So from the CT scans, you can see where the membranous septum is. So this is highly probably, these red dots here, these red dots is highly probably where the conduction system originates. What we have observed, and we have done a study on this, there is quite some anatomic variation on where this membranous septum is. So really, this is really patient-specific. And what we can do with the computer modeling, since it's finite element modeling, we can assess the impact of the force exerted by the device on the anatomy in that specific region. And by analyzing that, this is a study on, I think, 95 patients. You see here that the maximum pressure in patients that did not have conduction abnormalities seems to be significantly lower than the pressure which do have conduction abnormalities. So this pressure information allows us to give a better insight on these conduction problems. Of course, this is not limited to TAVI alone. We have been also active in developing similar technologies in the mitral space. In terms of mitral, we are still in R&D modus, but it's a very similar concept, where in the mitral side, we start either from CT, echo, or a combination of both. You have different procedural techniques which you can study preoperatively. So this is how we validated the model. I will speed up a little bit. So we made a computer model in one frame of the cardiac cycle. We had pressures measured inside the patients. We put that pressure in the computer model, and then we compare at a different moment in time with the medical imaging. And the correlation seems to be quite good. So here you see, for example, an overlay in white of the clinical images and in red of the computer model. Now, how can we use these types of model? One approach is, for example, to use this technology for procedure planning, again, of devices. So for patients that have a disease which is called MAC, not related to any hamburgers, but MAC means that there's a very severe calcification around the mitral annulus. For these patients, sometimes there is a choice of putting a TAVI device to try to solve the dysfunctioning mitral valve. This can be observed here. So this is a patient where in yellow you see what you can see in terms of the two mitral valve leaflets. In white you see that there's a very pretty severe calcification surrounding the origin or the orifice of that valve. Now here we can start by making a computer model of that anatomy. We have computer models of these devices, and preoperatively, again, you can assess the impact of putting a specific device there to learn, is there a good fit or not. Another type of approach that can be followed, so in mitral you have different technologies. You have repair techniques, you have replacement techniques. This is another technology developed by Abbott, where you do a clipping procedure, so you try to grasp both leaflets. And with this type of technology, we can assess the impact of putting one clip, multiple clips, and try to see what the best procedure would be for that particular patient. Of course, this needs further validation, but this is, let's say, where we're heading towards. I will conclude to stay in time. So both families of products, so both in the TAVI space, but also in the mitral space, we bring already added value both to manufacturers and hospitals in terms of R&D and procedure planning. And we believe, and I think we're not the only ones, that it offers unique insights in the interaction between the device and the anatomy, and that is, of course, complementary to any other 3D technology out there. I thank you for your attention.